Да се обръщаме към най-сигурното нещо, което съществува. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново. Защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академични институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.
More than 40,000 Teva employees who wake up every morning can be counted, as can the number of production sites in which they work around the world. What can't be counted is their motivation to enable someone, somewhere, to live better days with their loved ones. That's what counts. Teva provides 35,000 products to patients, more than any other pharmaceutical company. Every day, we deliver Teva medicines to pharmacies and hospitals in more than 60 countries. These are numbers we take pride in. But what really counts is our vast contribution to humanity. Our generic medicine saved hundreds of billions of dollars in healthcare costs over the past decade. We enable access for millions of people around the world to quality medicines. For over 100 years, Teva has pioneered scientific explorations, establishing 25 cutting-edge research centers, and strategically investing in biopharmaceuticals to the benefit of current and future generations. Today, our innovation has led to more than 1,000 generic medicines being developed. These are all impressive numbers that can be counted. But what counts the most is the positive impact we make on 200 million people every day, who can have access to a wider range of medicines to address their health needs. Cherish the priceless times together and live better days. till the end. Where's the light? I'll keep on searching, holding back till the end. Where's the light? I'll keep on searching, holding back.
Good evening, dear colleagues. It's my pleasure to open the second day of our Mixed Sophia Echo Days, which is organized together with the Royal Brompton Hospital. And my co-chairs this evening are again Professor Y. Lee and Professor A.N. Ho. We continue the second day with multiple variation of the adult congenital heart disease, and the first session will start with the morphology for the ventricular septal defect, and I am very present to give the word now for the Professor Ian Ho. She will start for the morphology of the ventricular septal defect. Professor Ho?
For this session, we're going to look at the ventricular septal defect and atrioventricular septal defect, and I'm going to show some of the morphologies in these entities, beginning with ventricular septal defect. To start with then, we need to look at the location. So we look at the right ventricle and call the inlet part receiving the tricuspid valve, the outlet part underneath the pulmonary valve. And of course, the third part is the apical part. The red line represents the atrioventricular conduction system. In terms of borders of the ventricular septal defect, we distinguish between muscular defects. These are the defects with complete muscular borders colored in yellow, versus the perimembranous defects, which have in its posterior inferior margin a fibrous border. And the third category of defects are the doubly committed and juxta-arterial defects. To start with then, muscular ventricular septal defect, as you see in this heart, we can hardly see it from the right ventricular perspective, but when I turn around to the left ventricle, you can now see it. It's coming into view here, and there's a muscle bar actually crossing the ventricular septal defect and the left ventricular aspect. By contrast, this defect is very high up. It's located quite underneath the aortic valve, as we see here in the middle where the forceps are now, just picking up the aortic valve. So it is a muscular outlet defect. The third version I'm showing you on the top right there, you do see the defect, partly hidden by the septal leaflet of tricuspid valve. Now in the left ventricle, you can see that defect more clearly now. You will note that it is not round in shape. In the bottom right video, I show you like a longitudinal 4-chamber cut through this type of defect, muscular inlet defect, and you see this defect just along here, the right ventricle, left ventricle, and the course of passage of this defect passing through this septum in this particular heart is actually oblique, not directly from right ventricle to left, but slanting upwards here. So the opening of the left into left ventricle is here, opening in the right ventricle was way down here. So we have then different shapes, different sizes of ventricular septal defect, although they're all muscular defects. But by contrast, the perimembranous defect is shown here, colored in orange on the diagram, and highlighting the proximity of that posterior inferior margin to the atrioventricular conduction bundle. Perimembranous defects have been known in the past under various terms and so on, just some of these listed here. So then this is the right ventricular view opened up, tricuspid valve just here, looking up to the pulmonary valve here. We have muscle between the pulmonary valve and the defect. And turning around to the left side, the left ventricle, left atrium, left ventricle opened. We can see now, here's the defect, the aortic valve, the mitral valve just hidden there, tucked away. And we can now appreciate this fibrous posterior inferior border to this particular perimembranous defect here. Look at the aortic valve, hardly any margin between the aortic valve leaflets and the defect. And very importantly, the posterior inferior margin here is exactly where the atrioventricular conduction bundle would be coming through when contemplating either device closure or surgical closure. It's important to note that. So in the subcostal kind of cut, this is actually a normal heart, and I've tried to position where one would find this kind of perimembranous defect. It would be somewhere in this region of the heart. And here the pictures are just to highlight the proximity of the atrioventricular conduction bundle stippled in red here, relative to the margin, the posterior inferior margin of that defect, where there's a little remnant of a membranous flap, a little remnant of the membranous septum of the heart. And here a longitudinal cut is an outlet, a perimembranous outlet defect, a little bit of overriding of the aortic valve leaflets, and a conduction bundle put in here with the branching, bifurcating right and left bundle branches in place. Now the perimembranous inlet defect versus a perimembranous outlet defect. So here in this plane, we see the aortic valve or semilunar valve relating to the defects, so it's in outlet position. By contrast, this is also a perimembranous defect, but it's sitting more in the inlet portion of that ventricular septum. You see partially closed, partially obstructed on the right ventricular side by the septal leaflet of the tricuspid valve. And when you scan in to this four-chamber kind of view, you will see the two atrioventricular valves, tricuspid and mitral valves, sitting in the roof of this particular location of a perimembranous inlet defect. The third variant, the doubly committed and juxta-arterial VSD, again, the different names given to it, describing the similar thing. So basically, very high up in the region of the heart, very closely related to both sets of semilunar valves. And we see one of these examples here, the right ventricle opened up. Here's the pulmonary valve, and right behind it, the aortic valve leaflets. There's no muscle separating the two sets of semilunar valves. Well, we note here that there's a muscular posterior inferior border to this to the defect in this heart, meaning that the conduction bundle is well protected from the border of the defect. And again, in this kind of subcostal approach, this is where this type of defect would be sitting. Similarly, another juxta-arterial ventricular septal defect, we see the proximity of the pulmonary valve and the aortic valve leaflets not separated by muscle at all, but here is the important part. The posterior inferior margin of this defect is perimembranous. It's because that defect has extended backwards to reach the region of the membrane, the remnant of the membranous septum. And here's the left ventricular view, rather, right to the back of the heart. So again, in this short axis cut, we see here this defect has extended backwards to meet up with this kind of defect, so confluent perimembranous and doubly committed and juxta-arterial VSD. In longitudinal cuts, for example, peristernal long axis kind of plane, we see here the roof of that defect formed by the fuse or conjoined leaflets of a pulmonary valve leaflets and aortic valve leaflets, no muscular separation in the roof. It's important to note that this kind of defect, although rare in the western part of the world, much more common in the eastern part of the world and in Latin America, is the associated aortic valve insufficiency, quite often seen. And the pathogenesis is lack of anatomical support for the valve and hemodynamic effects that push the aortic valve leaflet into the right ventricle, resulting in regurgitation of the aortic valve. So in summary then, the ventricular septal defect, we look at the location, the size, the margin, again, proximity to important structures. And of course, ventricular septal defects are very often associated with other cardiac malformations as well. And then importantly, the holes have different shapes and sizes on both the right ventricle and left ventricular perspectives. So moving on to now atrioventricular septal defects. What are they? Well, they've been known by various terms in the past: endocardial cushion defects, atrioventricular canal defects, and ostium primum ASDs, or atrioseptal defects. But they're unified by the fact that all these defects have a common atrioventricular junction together with biventricular atrioventricular connections. This is to say that we have two atrial chambers and each atrium is connected to its own ventricle. So we have a normal heart here on the left-hand side of the screen, looking down onto the mitral and tricuspid valve orifices. And you will note that these form a kind of figure of 8 configuration with the aortic valve in the waist of the figure of 8. On the right-hand side of the screen is an atrioventricular septal defect showing you a more oval kind of arrangement of the common atrioventricular junction that has pushed the aortic valve forwards. And the still images then highlight for you the differences between a normal configuration of the atrioventricular junction, a figure of 8 on the left side, and ovoid shape on the right side for an atrioventricular septal defect. So in the normal, you have tricuspid and mitral valves. In atrioventricular septal defects, we have a common atrioventricular junction with 5 valve leaflets guarding that common atrioventricular junction. And very often then we can find, we can always identify 2 leaflets that bridge the septum. So they're connected to both the right-sided and left-sided ventricles. And these are simply termed superior and inferior bridging leaflets. So there are 2 more leaflets exclusively to the right ventricle and 1 leaflet exclusive to the left ventricle. In situations like this one here, the lower diagram, we see the superior and inferior bridging leaflets joining together. So this entity then divides the left orifice and left atrioventricular valve orifice from the right atrioventricular valve orifice. So the number of orifices, common valve orifice or separate valve orifice, depends on whether the superior and inferior bridging leaflets are joined together or not. So just to look at the heart from the apex side of things, the normal configuration, you see the aortic outflow tract tucked in between the tricuspid and mitral valves. By contrast, in both of these 2 hearts, the aortic valve is not visible, it's sort of displaced more anteriorly, and we have still 5 leaflets. But in those separate valve orifices, you would then find 3 leaflets committed to the left-sided ventricle, and also superior and inferior locations of the peppery muscles supporting that left-sided part of the atrioventricular valve. So different from configuration from a mitral valve, in other words, where in mitral valve, there would be oblique orientation of the peppery muscles. But in atrioventricular septal defects, the peppery muscles are more superior-inferior relationships. And furthermore, the inlet length is shorter than the outlet length in hearts with atrioventricular septal defect. So there's inlet-outlet disproportion compared to the normal situation. But I think in terms of 4-chamber kind of views and imaging, the key really is the loss of offset between the left-sided and right-sided atrioventricular valve. So on the one panel here on the left, you have the normal situation where the mitral is inserted higher and the tricuspid lower down, the term the offset arrangement. This has disappeared in hearts with atrioventricular septal defect. We don't see that at all, and instead we usually see a hole in the middle of the heart. Variations, of course, in atrioventricular septal defect. In this example, we have interatrial communication only, and that's because the bridging leaflets have come together and are attached to the crest of the ventricular septum, as we see in this heart, the right-sided view, fused together, attached directly to the top of the ventricular septum, and similarly in the left-sided view. By contrast, in this specimen, the leaflets are not stuck to the crest of the ventricular septum, so there's then potential for interatrial plus interventricular shunting. And this is usually the form we find in complete or so-called canal form of atrioventricular septal defect. And the diagram shows you interatrial plus interventricular levels of shunting. Then there's this type that's called the transitional or the intermediate type, where the leaflets have fused together, superior, inferior bridging leaflets joined together, but have separate atrial level shunt and ventricular level shunt. So this kind of arrangement seen on the right ventricle and seen here on the left ventricle. And finally, where the leaflets are attached to the underside or the free margin of the atrial septum, this is what we get here, superior bridging, inferior bridging. And when the leaflets close, there is then the potential for interventricular shunting only. And turn around to the left side of the heart, we see that. Here's the defect, deficiency. The bridging leaflets are attached to the underside of the atrial septum, as we see here. So all that shunting is occurring underneath here, interventricular shunting. So this, in summary, the levels of shunting should be noted in this entity of atrioventricular septal defect. But then that's not the end of the story, because you also have to look out for associated malformations, right ventricle outflow tract, such as association with tetralogy of Fallot, which we will look at in a later session, and various other anomalies as well that can be associated. So in summary then, we have reviewed ventricular septal defect and atrioventricular septal defect. And I'd be happy to take questions. Thank you very much for your attention.
Thank you, Professor Ho, for the very interesting morphological part of this session. Any questions from the audience? I cannot see the question here. Could you give me the question, please?
There's nothing on the chat box.
They tried to send it to the chat, but it's not impossible in that moment. Maybe but this
maybe we come back to it later.
Maybe later, yes. Okay, so we will continue now with the next presentation, which is template for the echocardiography assessment of the ventriculoseptal defect and atrioventriculoseptal defect. It's my pleasure to introduce Professor Nada Al-Sakini. She is again from the Royal Brompton Hospital. Professor.
All right, hello everyone.
Yes.
Fantastic. So why don't I start with the slideshow? Okay. So I have to say thank you very much for the invitation today. Really much appreciate it. I'll be talking on echocardiographic assessment of VSDs and AVSDs, and I'm really conscious that I only have 10 minutes for each lesion. So it will be a fire round, and I will not be able to cover everything that I would like to cover. So the structure of the talk will be very quickly looking at the anatomy, but this was covered beautifully by Professor Ho, and the associated lesions, the importance of looking at the hemodynamics, and then the echo assessments, which is a very practical bit that I'm going to be concentrating on. Now, before I start, I would like you to draw all your attentions to this fantastic consensus document on an echocardiographical assessment of ACHD by the Brompton Group. And I don't know if you can actually see it. Please shout out if you could see it.
Yes, we can see it.
Fantastic, fantastic. Thank you. Now, this is online and everyone has access to it. This is what it takes to actually do a proper echocardiography. And it's the bread and butter of what we do in ACHD echo. Now, if I start with VSDs, as you can see here from this consensus report for the classification of septal defects, I mean, it is an exhaustive list. So I'm really not going to go through this. I'm going to be simply talking about the 4 simple types of VSDs as per Yuen Ho. Now, it will make things easier if you look at this.
Sorry, Nada.
Yes,
Nada, you need to put.
I can't hear you, Prof.
So you need to put a display setting. It's not right. You got your speaker notes on the side or not display properly. You go to display setting on the top.
Yes.
Click and go to full screen. Sorry.
Display settings.
Yeah.
Yes. Okay. Is this better for you? Is this better, Prof?
Yeah, that's better. Go on now.
Okay.
Sorry.
So this is the International Society of Adult Congenital Heart Disease, and this is the consensus document that they have for each of the defects. This is the one for ventricular septal defects. And of course, what you need to do is the same as you do for everyone: subcostal, peristernal, apical, and suprasternal. Now, looking at the hemodynamics, the first question that you will always be asked about VSDs is which is the chamber that tends to dilate? And we really need to think systematically about this. So the main function of the heart, as you know, is to maintain cardiac output. And when there is a VSD here, some of the blood in that left ventricle will cross to the right. So in order to maintain the volume, the LV needs to fill with more blood to compensate for the decanted blood to the other side. So the actual chamber that tends to dilate is the LV, not the RV, as a lot of people think that might be what happens. Now, the hemodynamic effects of this shunt depends on the size of the shunt and the direction of the shunt. So if it's a small shunt, like that is almost, you can almost see it here, but it's a very small shunt. So the pressure and volume will be quite low going through the RV and the pulmonary circulation. So really the hemodynamic sequelae of that are not big. However, if the LV starts to dilate, then you will start thinking that this VSD is hemodynamically probably significant. Now, on this short axis view, you can see this is the aorta on aortic valve on short axis. This is a huge VSD where that RV is. Now, this is a big VSD that will have pressure, volume, loading of the lungs, and this will end up with pulmonary hypertension. So going through the simple, the 4 types of the VSD. Of course, as Prof said, we need to know the defect, the size, the location, and we need to do some quantitative analysis. So on here, at the bottom, you can see that there's this rim of tissue here that really does not look normal on this peristernal long axis view. And when this happens, you really need to keep in mind that this might be a defect, because this is where your perimembranous defect is. And when you see such a thing, the first thing you do is to put a color Doppler on it, and all and behold, and you do have some shunting there that's happening from left to right. And the reason I know that is because when you put a Doppler on it, a CW, you get the jet coming and it's going towards the probe. And it's the same thing. On a short axis view, you can see it right here, just underneath that tricuspid valve. There is a bit of tissue there that looks abnormal, and there is a shunt. Of course, the way we calculate the RVSB, especially here, if there's a TR, there could be some contamination. So the way we calculate it is you get this maximum gradient, which here is about 122. You subtract from it the systolic blood pressure, because this pressure over here is contaminating the right side. So you subtract the systolic blood pressure from it, and that's when you get your RVSP when you add the right atrial pressure to it. Now, the other things to look at when you have a VSD, you need to see part of the hemodynamics. You need to see if the RV is hypertrophied, if it's causing any loading onto the left ventricle. So this is a D-shaped septum ventricle where the interventricular septum is squashed by all the pressure from that right side. The other thing, this LV looks dilated. So this is another hemodynamic sequelae that you all need to keep in mind. Now, another type of VSDs is the muscular VSD. Now, just looking at that LV, it looks visually dilated. So, but I can't see any shunts here. So what I do is I sweep up through the VSD, and you can see that there is a shot there where you have some sort of a turbulence. And if you look carefully at it, there is actually a muscular VSD through that intraventricular septum. And every time you have any turbulence, you have to put a Doppler through it. And as you can see, it actually is of higher velocities. The other types, as you can see here, this is another muscular VSD. This is a beautiful demonstration of quite a malaligned VSD. You can see color going through it. This is a rather extreme example here on the right-hand side, where you see a muscular VSD of large proportions, a hypertrophied RV, and this is it actually has a bilateral bidirectional shunting, and the patient has pulmonary hypertension because of this huge VSD. Now, the other type is a doubly committed VSD. Now, for those who are not trained in looking at pediatric echoes, they are actually the right way round. And you can see these are the two ventricles here and the two great arteries there. And there is, as you can see, a defect with a shunt of blood going through. So it is subarterial or juxta-arterial. On these views, this is a zoomed in short axis view. This is the aortic valve, and that's the pulmonary. And really, this is the position where you see the doubly committed right here, the doubly committed VSD, as opposed to the perimembranous VSD, where you see it on that side over there. This is a 3D reconstruction of the middle one. This is the pulmonary artery, and you have the aorta somewhere here. It's been cropped, and you can see that the defect is in between. And as usual, you put your Doppler through, and you have a 4 meters per second shunt, which means it's a restrictive VSD. Now, the doubly committed, as Professor Jan Ho said, you do have the issue with the prolapse of the right coronary cusp, as you can see over here. Therefore, you have to keep an eye on aortic regurgitation, and the quantification of aortic regurgitation is the same as we do for all of them. Color Doppler, vena contractor, you do pressure half time, and you have to look at the subcostal, suprasternal arch flow reversal as well. Moving on to other things that we look at. So on here, you have to have a little bit of faith, but trust me, this bit where it's quite shiny, this is where the VSD patch. So, you know, there are two types of dealing with, or three types actually. We either leave these alone, or we go through surgery and put a patch in, or we put a device in. Now, these devices, these patches can have shunts in them, so you have to put a color on there, and you have to check whether there's a residual shunt. The other thing that is of importance, and it's extremely important when it comes to the clinical context of a patient, for example, coming in unwell and you don't know why. This is a TOE, that's the RV, that's the LV, and that's the aorta. And you have this patch that looks really bright, or you have this beautiful mobile lesion that looks like very much infected endocarditis, which actually it was. The other thing is the complications that can happen, or an association that can happen with a double-chambered, or we call it double-chambered RV. Now, just keeping in mind, knowing that there is a VSD, and knowing that there is just a request with a murmur, you have to really be cognizant of what you might be finding as you go along. So on here, the top left, you actually can't see anything. But as you tilt up, you will start getting and going clockwise, start getting the aorta or the LVOT outflow. You can see here there's probably a subaortic ridge, which is also something associated with VSDs. Now, when you look, you sweep up a bit more, you start getting the RV here. And from the RV, this is the pulmonary artery. And in between, you see that there is a narrow gap there with some flow turbulence. And when you get that, you really ought to put a CW through. And as you can see, there is quite a high, 4.5, 4.8 meters per second. So this is pretty high velocity. So there is a narrowing there. And what it means to be a double chamber is that there would be a growth of part of that RV, a muscular growth, just across to the VSD. There's a hemodynamic theory behind this. Therefore, we have to watch out for it, because at some point, get severe enough, it will require surgery. But the important bit is actually to identify it. This is the other view. When you do a counterclockwise movement, you get your RV and your RV outflow tract. And then you see here, you have a good turbulent flow with over 4 meters per second there. Unfortunately, it doesn't look bright all the time, and that's why we use a lot of Doppler to identify it, and color. So please don't forget about that. The other things that we also use are device closures. And I'm not going to be talking about the indications or what's suitable and when we close it or not, but just looking at this, you have a dilated LV. You have a defect that's coming in and out of view there. On a short axis, you can see, and it's the opposite for those who don't do TOEs. This is actually the RV, the opposite way of your normal TTE, and this is it's like basically a short axis view. And you can see there's a lot of redundant tissue from the tricuspid valve, and the defect is there. And you can see it here. That's the same picture on a 3D reconstruction. Now you have to, of course, look at the size, look at the shunting, and see if it's suitable for closure. Now in this case, this is a more like a LV outflow tract on a TOE. This is the LV, that's the RV, and that's your aorta. There's actually nothing wrong with that septum, as you see. However, when you start tilting, look what happens here. You can see that there is this huge defect. Now, this is actually was amenable to closure, and we did successfully put a device in, and this is one of our devices there. You can see it's got 2 discs and a body. It does look scary, but trust me, what you need to do is you do all your measurements and your assessments. So you have to go through the tricuspid valve, making sure that it's actually functioning okay and you actually haven't caused any stenosis. You look at your mitral, you look at your aortic. I mean, imagine if you put it here, you might block this outflow tract. So you need to really make sure that it's not blocking anything in its way. The other thing that you need to make sure is that how much shunting there is. There's no point if there's severe shunting. So here in this case, there's only trivial shunting. The other things to talk about is whether it's an unrepaired. So we can repair it by 2 ways, but also it might be unrepaired. So this case is a very large VSD and an overriding aorta. As you see, part of it is in the RV, part of it is in the LV. The things to look out for, of course, is this hypertrophied RV, how much shunting there is, and in this case, of course, there is bidirectional shunting, and the systemic, the RV pressures will be systemic pressures because there's equalization of pressures. On this 4-chamber view, it's just the same. You can see a very hypertrophied RV. You need to check and measure the sizes of all the chambers, and it is, you can see the right side is quite dilated, the RV and the RA, and the RV is hypertrophied, but that needs to be measured properly. I think this is a beautiful example here of how hypertrophied it is. You will get a point knowing that this is hypertrophied RV, but also under high pressure causing squashed ventricle. And that's your bidirectional shunt there. The other things that we need to look at are the pulmonary valve. We need to look at any regurgitation. So for example, when there's regurgitation like this, even though it looks trivial, you need to put a Doppler through that. And when you do, you will manage to get the diastolic pressure there. And when you do this, this gradient plus the RIP, right atrial pressure, will equal to the RVSP. So 15 plus 3, that's 18. The other thing also to note is the pulmonary acceleration time. The shorter it is, the worse it is, and the higher pressures, pulmonary pressures there are. So anything below 105 milliseconds is short. Also of note, this notch is important, and it indicates increased pressures, pulmonary pressures, because it stops it at its tracks. Of course, without me needing to say, you do need to get a TR max. So your TR velocity here is 5.2 and your mean gradient is 111. But there's no point in putting 3 for the right atrial pressure here. You will go straight for 20. So this will be around 130 millimeters of mercury as an RVSP. This is how you measure your pulmonary acceleration time. Now, one of the important things is noting how much filling time there is. This is the filling time here, and as you can see, it's quite short, and it's way shorter than the regurgitation time. So you actually don't have much time to fill, and this is a bad sign, and it's called the SD ratio. Now, other things, of course, you have to do all your measurements, your left atrium, right atrium. You have to take the measurements for the RV, the LV, the ejection fractions, and for the right side, a proper RV view for the fractional area change. You do all your TVIs and TAPSEs as well, and get your composite score from there. At the end, you have to write an echo report, a nice template, and these are the things that you need to take step by step to look at so that you can have a reproducible template. Now, I'm going to very quickly go through the atrioventricular septal defects. However, all the things that I've spoken about in VSDs, they all apply here in AVSDs. So as Professor Ho mentioned, you will need to look at all of these things: the offsetting of the valves, how many valves, the unwedged aorta, and how much LVOT that will cause, how much regurgitation these valves will have, how much is it repaired, is it unrepaired, what type of AVSD is it? And I'll come to that in a second. We have associated lesions, but this will be a talk for another time, but you have to keep an eye on these. And then again, there's another consensus document, a beautiful document as a roadmap for doing your assessment, echo assessment for atrioventricular septal defect. And again, it boils down to the same things. Looking at the valves, looking at their caudal attachments, the shunts, whether they're regurgitant or not, whether there's obstruction, the size of the components, whether they're big or small, the atrial and ventricular, and looking at the ventricles and whether there's dominance or not, and I'll talk about it in a second. Of course, there will be some prosthetic material in a lot of patients, and the presence of pulmonary hypertension. So, looking at this, the first type is the complete AVSD, and you have a big atrial component and a big ventricular component and the common ring. And this is how it looks on a 3D. You have a superior bridging leaflet and an inferior bridging leaflet, and you have all the leaflets on the other side. This is the ventricular component there, and the atrial component here. Of course, the hemodynamics of these, they all depend on the shunt. It depends on how many, where the shunt is. So if it's just an atrial component, then you know that the right side will get dilated. If it's a mixture, it will be a mixture of both. And then if it's really large, you might cause pulmonary hypertension. And also depends on how quickly they have repaired these lesions. The other type is the premium ASD. As you can see, there's absolutely no offsetting of the valves, so they're all at the same level because they all come off the same ring. You have the premium ASD here and no ventricular components. On the other hand, the sort of midway between the two, you have a bigger atrial component, a smaller ventricular component, and a tongue of tissue in between. And this is how it looks. This is the atrial component and the ventricular component. And this is us looking downwards from the atria, and you can see the rim of tissue in between both, but they're all the same level, absolutely the same level. Okay. So when you, apologies for that, when you look at these, you need to know what's what. So this is the zone of apposition here. So if they're going to close this, you're going to get a little gap here. And this gap, they will saw together, but they will not saw it completely, because if they did, they might cause left AV valve, or which is the mitral valve, but we call it left AV valve stenosis, which is not something that we want. So so what happens is, when it's not completely closed, you do get a little, it's not a cleft, but it's a zone of apposition, and you do get some regurgitation there. And this needs to be quantified and looked at properly. The things that you need to know is, what have people done for them in the past? So when they come to you, you can have a 2-patch repair, you can have a 1-patch repair, and they close some of the zone of apposition there. It all depends on the Rastelli classification, whether the type, the nature of these valves, the type of the valve, the type of the tissue, where they have been inserted. If they're inserted on the opposite side, like difficult to cut them off. If there is, of course, any dominance of one ventricle, and in that case, if the surgery is not possible, then you go to the Fontan operation route. So this is the zone of apposition, and you can see there is a lot of regurgitation there. And of course, you need to quantify the regurgitation with PISA, with vena contractor, if feasible. You need to, and you have to measure mitral valve VTI and the effective orifice area, effective regurgitant area, sorry. You have right and left, and of course the right can be regurgitant as well. And as you can see here, both of them are severely regurgitant in this case. Other things, the hemodynamic effects, you can see the LV is dilated, the left atrium is dilated. You have to do all these measurements. You have to do your DVIs, you have to do your TAPSEs and your fractional area changes. One of the things that are associated because of that gooseneck can be some of that outflow tract obstruction. You can see sometimes it's a piece of tissue there, and in this case, it's causing some stenosis, but it's also causing regurgitation. And you will have to measure it the way you measure any aortic regurgitation. This is also showing you how narrow it can be on a TOE. Again, there you have to look at the patches that we use. So this is a patch, this is an atrial patch here. This is a ventricular patch on parasternal view for the BSD. This one is for the ASD. And you have to check if there is, if there's any shunting, or if there's any residual problems there, or any infective endocarditis, if that was a problem, depending on the clinical scenario. Now you could see here after this repair that this mitral valve is really not opening well. So you have to really interrogate your AV valve. Sorry, I called it mitral valve. I should call it AV valve, the left AV valve. And when you do your measurements and you do the mitral Dopplers here, you can see that the mean gradient is 12.7, putting it into the severe mitral stenosis range. This is a rather extreme form. This is a TOE, so it's upside down or the right way up, if you like to call it. This is a common atrium, and there's a big patch here. So you have to really make sure that the patch is nice. You put color on it, make sure that there are no issues there and no shunts. Of course, these valves can be replaced, and they are, in this case, replaced by a metallic valve in the mitral position. And you have to make sure that, as you can see here, both mitral openings of these discs for the metallic valve are opening well, and you do your Dopplers through it. And please note, it's not just about saying that there's, you do not compare them with normal valves. The measurements are not the same, and serial measurements as well are very important. What's striking here is that there is this massive biatrial dilatation and really small ventricular components. And this is really a very bad case of diastolic dysfunction in this case. And of course, for the unrepaired, everything we said for the VSDs holds true. On a subcostal view, you see how hypertrophied the RV is. You check your components. You check the function of your ventricles, how big your atria are, what the regurgitation is like. And then again, you put your Doppler through that pulmonary regurgitation, even if it was absolutely trivial, but you can get a really staggering mean pulmonary artery pressure. And again, the TR velocities, and please do the SD ratio, the systolic diastolic ratio. And finally, of course, you also have to write your template, and it has to be nice and succinct and up to the point, and telling people what you want to tell them. Now, I have to really thank all of those lovely people, including Professor Wei Li, my mentor, and my great friend. So in conclusion, VSDs and AVSDs are spectrum of lesions. We need to know the anatomy, what hemodynamic effects they have. We need to know the procedures that they have undertaken, looking for the residual lesions and associations. We have to have a consistent, reproducible reporting. Thank you very much.
Thank you for the nice presentation, Dr. Sacchini. There is one question on the chart. What is the main differences between the inlet VSD and IVSD interventricular shunting?
Between, sorry, the inlet and which one?
In inlet VSD and AVSD interventricular shunting.
So the AVSD and the inlet VSD. So the inlet VSD is the component of an AVSD. Basically, it's the ventricular bit of the AVSD. So if you have a complete AVSD, then the ventricular component of that is an inlet part of that VSD. So it's basically part of it.
Okay, thank you. Professor Lee, do you have any comments?
I think this inlet VSD and AVSD, sometimes it can be confusing. Maybe Ian can give a little explanation as well.
I think the inlet VSD refers to a kind of perimembranous VSD, which is very much extending backwards in the inlet portion, not so much referring to a muscular inlet VSD. So in terms of location, it would be very similar to an AVSD, that has only interventricular shunting. So in terms of level or location-wise, it's similar.
But sometimes in late VSD, we have normal mitral valve. Is that always the case or in some cases?
Correct. With an inlet VSD, I would say you have a mitral valve and you don't have the expanded atrioventricular junction, meaning that your aorta is in the correct position. Whereas when you have an AVSD, the aorta is displaced forwards and you have an elongated outflow tract.
Thank you, Yan, to clarify that. You know, we all confused by this kind of terminology. Clinically, sometimes we said it's kind of inlet VSD, but the patient doesn't have AVSD. So I think morphologically, there can be some difference.
Correct. And I know in North America, it's very common. They call AVSD inlet VSD.
I see. But is that in inlet VSD, you always have left axis deviation as well?
You have an elongated bundle, common bundle. So I would anticipate.
So you will have.
Yeah.
Okay. Thank you very much. Excellent talk.
Thank you. And we can continue with the next presentation. It's my pleasure to invite Dr. Giancarlo Scamanillo. He will speak about echocardiographic assessment of the late complication of small VSD repeated IVSD.
Good afternoon, everybody. First of all, I would thank for inviting me to this amazing course on echo in adults with congenital heart defects. I have now been in Sofia. I hope to be with you one day and to share with you your wonderful city. And I'm sorry to not being with you in live session. However, I hope to give my small contribution to this meeting, talking with you about late complications of small VSD. We all know that small, restrictive, isolated VSDs are thought to have an excellent long-term outcome and are usually treated conservatively. But on the other side, there is some evidence that their clinical course may not always be benign, so they need a careful evaluation through adulthood. But first of all, when we define a VSD small, so we may define a small VSD from different perspectives. For example, from a hemodynamic perspective, a VSD is small when QPQS is less than 2:1 or less in absence of pulmonary hypertension or pulmonary stenosis, and PVR is less than 3. Or from echo perspective, we know that echo and that the meeting is on echo in adults with congenital heart defects. Of course, echocardiography is the main tool used for assessing, evaluating heart defects, and we may define at echo a small VSD usually when diameter is less than 0.8 to 1 centimeters, or when peak velocity across VSD is higher and higher than 4 meters per second. Or from a clinical perspective, when we have absence of symptoms, there is a pansystolic normal and chest X-ray is normal with normal heart size. But which are these related complications that we will describe? We may observe aortic regurgitation or a double-chambered right ventricle, infective endocarditis, or LVOT disease, and also called VSD-related cardiomyopathy. So let's have a look at aortic regurgitation. Different mechanisms may be involved in the genesis of aortic regurgitation. We may observe aortic prolapse or subaortic stenosis or the coexistence of an abnormal aortic valve, for example, a bicuspid aortic valve, or the occurrence of infective endocarditis. Let's have a look at this slide where we observe a regurgitant jet of aortic regurgitation and look at the valve from a short axis view. You can observe that there is a partial fusion of the two coronary cusps. So we are observing, we are showing a bicuspid aortic valve, and from this off-axis for chamber view, we may clearly see a small perimembranous VSD with a high velocity jet. But the typical aortic regurgitant jet associated with the VSD is represented by the jet by the low plipetsis syndrome, where we have usually a perimembranous VSD or subpulmonary VSD, a small perimembranous VSD, as this shown in the first image, in the first video. And from this short axis view, we can clearly see that there is a tricuspid aortic valve with a prolapsing right coronary cusp into the defect, which is restrictive, as we can see from this spectral Doppler analysis with a high velocity regurgitant jet. And from 5 chambers view, we may clearly observe both the regurgitant jet of aortic regurgitation and the small perimembranous VSD, so the location of the defect. And aortic regurgitation, we have said before, that may be observed with this mechanism, particularly in patients with the perimembranous and subpulmonary defects. In particular, in perimembranous defects, the pathogenesis, the aortic regurgitation is observed in about 5% of cases, and the pathogenesis is represented by the defect of commissure between the coronary and the right cusp. On the other side, in subpulmonary VSD, which is much less common than perimembranous defect, we may observe in a vast majority of patients aortic regurgitant jet in about 70% if the VSD is larger than 5 millimeters, since in this case the pathogenesis is represented by deficiency of non-coronary cusp support. And the Venturi effect is the predominant factor in the development of aortic regurgitation associated with a VSD in these cases, in this low plipetsis syndrome. In fact, we may observe that a negative pressure created by the high velocity jet across the VSD is responsible in turn of a prolapse of the cusp, usually the right coronary or non-coronary cusp across the defect, and of course it will generate a jet of aortic regurgitation, aortic valve incompetence. But if this mechanism is a functional mechanism, if it persists during adulthood and during time, it may be responsible of a change in the structure of the aortic valve in terms of cusp retraction, aortic anus dilatation, and the deformation of the sinus of Valsalva. And these damages, of course, may be irreversible. And of course, it has important implications for management strategies. In fact, in these studies, we may observe that when we observe aortic regurgitation and close the VSD, a 10-year reintervention of the aortic valve may be required in about 50% of cases. And in particular, when at our assessment, both prolapse and aortic regurgitation are present, after VSD closure, during the follow-up, postoperative aortic regurgitation may be observed in about 60% of cases. So it's very important to assess and to grade aortic regurgitation, since the recent guidelines from ESC in 2020 state that in patients with VSD associated prolapse of an aortic valve cusp causing progressive aortic regurgitation, surgery should be considered with a class of indication 2A. So it's important to observe progressive aortic regurgitation. So we should measure aortic regurgitation with direct and indirect parameters of severity, and to grade and to compare, since any increase in the grade and severity of aortic regurgitation may require surgery in order to surgery and closure of VSD in order to avoid irreversible complications on the aortic valve itself. Another complication is represented by a double chambered right ventricle, which is present in about 30% of VSD, small VSD. In most cases, VSD is perimembranous, and flow turbulence in RVRT induced by the high velocity jet across the VSD may trigger in some patients an abnormal RV hypertrophic response, which is responsible of the obstruction, and it tends to progress in severity over time, becoming clinical manifest, in particular in terms of reduced effort tolerance, progressive dyspnea during adult age. This is a case of a 42-year-old man in a functional class 2 with symptomatic hepatic ventricular premature beats. From this short axis view of the aortic valve, we may observe a trace of aortic regurgitation and a small perimembranous VSD with a high velocity left to right shunt. And this is confirmed from this 5 chambers apical view. But from the subcostal view, which is very useful in this case for diagnosing double chamber of the right ventricle, we may observe all the features of this complication. In fact, we may clearly see the tricuspid valve, so the RVOT, so the right ventricle, the body, the inflow part of the right ventricle, and the outflow part of the right ventricle, the pulmonary valve. And in between, we may observe, we clearly observe a muscular band, a muscular ridge, which is responsible of RVOT obstruction. And it's important to observe how close it is to the small V and restricted VSD. And this is the same patient before intervention, before surgery relief, and after surgery relief of a muscular obstruction, where we clearly observe the complete disappearance of any turbulence in the RVOT. This is another case of a 38-year-old woman where there is evidence from this off-axis view of a perimembranous restricted VSD and an acceleration in the body of the right ventricle, which disappears after surgery. In fact, we can observe the disappearance of VSD and disappearance of any turbulence after repair. Infective endocarditis is another important and in some cases, catastrophic complications of VSD. It has been estimated that a 20 to 30-fold increased risk for strengths, a 20-fold to 30-fold increased risk compared with the general population. And which are the most common sites of infection in these cases. In a study in 2017, Gabriels demonstrated that vegetations were the most frequent echocardiographic lesion, and it was located either on VSD, of course, but also on the adjacent valves, in particular tricuspid valve and aortic valve. In another study in 1998, the most frequently affected were the aortic and tricuspid valves, which are contiguous to the defect. We also evaluated and studied patients with small VSD, and we found a very high incidence, about 10% of infective endocarditis. Of course, we may consider a referral bias since the Brompton Hospital is a tertiary center. But which were the most frequent infection sites in our population? Well, VSD alone, but also VSD associated with vegetations on the adjacent valves, tricuspid valve and aortic valve. And 3 patients experienced pulmonary embolism, 3 patients had more than one episode of endocarditis, and 6 patients required underwent surgery. And it's very important to observe that was due to the complications of infective endocarditis. We may observe an upgrading of level of indications for closure of VSD in patients with a history of infective endocarditis. In fact, in 2010, it was 2B class of indication, which has been upgraded to 2A in the recent 2020 guidelines. But in most guidelines, there is still lack of indication for prophylaxis for infective endocarditis in this particular subpopulation. Alveolar obstruction is another complication of small VSD, since the relationship between small ventricular septal defect and subaortic stenosis is well documented, and it could be speculated that there's that fibrosis occurring during spontaneous closure and incomplete closure of a subtricuspid defect may be a cause and may explain the occurrence of such a complication. This is a theory image showing some features of a small perimembranous VSD. First of all, we may observe the perimembranous VSD with a high velocity jet between left ventricle and right ventricle. We may also observe the right coronary cast prolapsing into the defect, and just very close to the aortic valve, underneath the aortic valve, we may clearly see a small fibrous ridge, which is responsible for the alveolar obstruction. And last but not least, a very intriguing complication, very associated with VSD, a VSD-related, so-called VSD-related cardiomyopathy. A cardiomyopathy characterized by dilation of the left ventricle impairment of systolic and or diastolic function in patients with small VSD. So different mechanisms have been postulated that could be explain this cardiomyopathy. And intrinsic myopathy has been documented in some patients with concomitant presence of VSD or valvular disease such as aortic regurgitation or tricuspid regurgitation, or asynchrony of a synchronous pattern of contraction in the left ventricle, in particular due to the presence of the VSD. In particular, the abnormal septal contraction is responsible for an increased strain on the opposite lateral wall, or impairment of diastolic properties of the left ventricular myocardium, which may be increased due to acquired disease such as coronary artery disease or hypertension, or the whole VSD is not so small as we think. And we evaluated in our study 231 adult patients with isolated small VSD, and in 164 of them we had serial echo assessments. We may observe that in most of cases a left ventricular ejection fraction was normal, but in some cases we observed an unexplained by other causes reduced ejection fraction. On the other side, we also focused our attention on the left ventricular and systolic diameter, and in particular, a value higher than 4 was considered abnormal. And we may observe that about 10%, so a not negligible proportion of patients showed values higher than 4. Why left ventricular and systolic diameter? Because it's an established predictor of outcome in various cardiac diseases, such as coronary artery disease, valvular disease, or heart failure. And when we categorize our population according to left ventricular and left atrium size, we may observe a very interesting subgroup of patients with a normal left ventricular size, but dilation of the left atrium. So in this case, we may observe some alteration, some impairment of diastolic function, diastolic properties of our ventricle. This is a case of a small VSD with a dilation of the left ventricle, of both left ventricle and the left atrium. And when we observe the pattern, the pattern of the Doppler pattern across the VSD, we may observe a restrictive pattern with a velocity higher than 4 in systole, but very interestingly, we may observe the persistence of a significant higher than 1 meters per second flow across the VSD during diastole. So in these cases, it could be explained by an increase in left ventricular stiffness, for example, due to aging, hypertension, diabetes, and so on, which is responsible for a raised left ventricular and diastolic pressure. So the left ventricular and diastolic pressure, of course, will cause a diastolic persistence of left to right shunt. And of course, so we have shunt not only in systole, but also in diastole. And of course, it could be a potential increase of left ventricular volume overload. So, which are our take-home messages? We may see that small VSDs have a low but real risk for developing late, sometimes severe complications. A lifelong follow-up is warranted for these patients, and echocardiography remains the fundamental first-line imaging modality for the assessment and follow-up of these VSDs-related complications. And advanced echo technology may provide further help, in particular by identifying some clinical myocardial dysfunction and shedding light on cardiomyopathy in this population. I will thank you again for your attention.
Thank you so much, Professor Giancarlo. Very interesting and very amazing, brilliant presentation. There is one small question, but because Giancarlo is not available to be online this evening, I would ask maybe Professor Lee, she will be possible to answer. There is the question from the audience: why in double chambered right ventricle patient has reduced the fault tolerance? Maybe we can.
I can answer this question. Yes, you know, in the double chambered RV with VSD, it's equivalent to severe pulmonary stenosis. So patient will have reduced cardiac output. That's the main reason they have reduced exercise tolerance.
Okay.
Is that okay?
Yes, I think it's okay for this answer. And there is no more other questions.
No other question now. That's good. If you have more questions, please keep writing. We can answer even in the next session. Maybe people need to think what they have to digest a bit.
Okay, so we will